Hello, my name is Adam Briggs, and I'm an assistant professor of psychology at Eastern Michigan University. I've conducted clinical research in the area of assessment and treatment of severe behavior disorders for over 15 years and published well over a dozen peer-reviewed studies and chapters in this area. Today, I'll be describing the outcomes of these and other recently published studies and discussing how you can incorporate advances in functional analysis methodology into your practice tomorrow so that you can effectively assess severe challenging behavior in a safe, efficient, and practical manner. But first, let's go back in time where functional analysis methodology did not yet exist. These are the dark ages, in that our behavior modification technology is powerful but primitive. That is, although the first behavior modifiers at this time understood the power of contingencies and programmed potent consequences to produce behavior change, there was less focus on understanding why the behavior occurred in the first place. As a result, behavior modification approaches came under scrutiny for their emphasis on powerful arbitrary reinforcers or reliance on punishment contingencies. Around this time, two primary scientific events occurred that served as our field's candle in the dark and ushered us into an enlightened age. Specifically, the first event was Ted Carr's 1977 publication, which was a review paper that summarized all the available literature on severe challenging behavior that offered compelling scientific evidence for operant explanations of behavior, which then subsequently led to Brian Owada's 1982 publication of the first comprehensive functional analysis methodology, or a pre-treatment way to identify what reinforcers are maintaining the challenging behavior in the environment. These events influenced a paradigm shift in our field as it set the occasion for thinking functionally about treating severe challenging behavior. Now, the advent of functional analysis, or FA methodology, allowed clinicians and researchers to develop effective function-based interventions to decrease the occurrence of challenging behavior. That is, once the variables responsible for maintenance of a challenging behavior are discovered, interventions can then be derived to decrease the motivation to engage in the challenging behavior, eliminate the reinforcer for the challenging behavior, or provide that reinforcer for an alternative response. In fact, previous research has shown that interventions based on the outcome of FAs are more effective than those that are not, and this has also resulted in a decrease in using punishment to reduce behavior. Although there's an overwhelming amount of empirical support for the use of FA methodology, behavior analysts sometimes avoid its use due to implementation challenges. These include the time needed to conduct the FA, the expertise needed to conduct the FA and then analyze the data, potential difficulties associated with assessing certain forms of behavior, lack of an adequate setting or space to conduct the FA, and potential danger or harm associated with conducting FAs of severe challenging behavior. Therefore, the purpose of this presentation is to explore advances in FA methodology and review considerations for improving the safety, efficiency, and practicality of assessing severe challenging behavior. Specifically, I will first provide an overview of functional behavior assessment methods. Then, I'm going to review best practice considerations for designing and conducting an FA, followed by recommendations for analyzing FA outcomes. Next, I'll spend a substantial amount of time discussing procedural modifications that can be applied to address implementation challenges and for clarifying inconclusive FA outcomes. Finally, I'll cover some general practice considerations and discuss directions for future research. So before we dive into design and how to conduct an FA, I want to spend some time covering functional behavioral assessment methods. Specifically, I want to review what we mean when we say challenging behavior. And I want to cover some common behavioral functions to provide some context prior to discussing the functional behavioral assessment approach. So in order to make sure we're all on the same page, I want to describe what we mean when we refer to behavior. That is, it's anything that a person says or does, and it must be observable, definable, measurable. And when we discuss challenging behavior, we're referring to behavior that becomes problematic because it occurs too much or too little, or in the wrong place at the wrong time. Or when it does occur, it poses a risk to the individual and others. Or when it occurs regularly, it interferes with the individual's ability to engage in everyday activities, thus limiting the amount of learning opportunities they might otherwise experience, which just has an overall impact on the quality of life for that individual and the others around them. Some common examples of severe challenging behavior include self-injurious behavior in the form of head banging, hand biting, aggression, in the form of hitting, kicking, hair pulling, property destruction, running away from a supervised area or elopement, as it's referred to, and pica, or the ingestion of inedible objects like pebbles, paper clips, pennies. So other topographies of behavior that are not necessarily as severe, but still pose a challenge because of how they may disrupt learning are stereotypic or self-stimulatory behavior, tantrums, and non-compliance. So in order to effectively treat these challenging behaviors, we must first understand how this behavior originates. To do so, we must consider how the individual's biology, personality, and environment all factor into the emergence, shaping, and maintenance of the challenging behavior. First, the individual's physiological predisposition is based on their genetic endowment and occasions or limits the behavioral capacity of the individual. However, one's physiology does not produce specific challenging behavior. Second, although an individual's behavioral symptoms may lead to the clinical diagnosis or a mental or emotional disorder, this diagnosis does not serve as an explanation for these behavioral symptoms. Instead, the individual's learning history leads to the emergence and shaping of new behavior, and certain experiences can result in that the individual learning to engage in severe challenging behavior. So, for example, perhaps the first time you take your child to the grocery store, you let them pick a treat from the checkout lane because they did such a good job. They sat in the chair, they kind of kept their arms in the cart. Maybe they were just kind of in awe the whole time. However, the next time you return to the store, maybe you still say, hey, if you're good, we can get a treat at the end. But that's a lot of waiting. And so all they do while you're in the store is they talk about getting a treat, they whine, they cry, and it's just an awful experience. But you decide, like, you know what, I can ignore this. They're not going to get their treat because they're not acting the way that we talked about before coming in here. I'm just going to do my shopping real quick and get out of here. Then they bust out this move. And you're trying to get them to get up. They won't get up. They won't listen to your requests. You try to coax them, but they're just not budging today. And then all of a sudden you notice that people are starting to watch your daughter lay on the dirty floor, and they're making comments of, oh, that floor is dirty. And there's people coming around with carts that are trying to get around her. And people are kind of staring, and it's kind of starting to create a commotion. Then you look at your watch and realize that you're running late to this appointment that you have to go to, and your kind of day's getting all out of whack. And so you just kind of decide right then and there that you're going to give in, and you say, okay, fine. If you get up, I'll get you the treat. So now each time you go to the grocery store or any store, this is your new normal. You have to deal with crying, whining, tantruming. But what just happened, and how did it happen so quickly? So when considering this everyday example, it's clear that this behavior serves a purpose. That is, your daughter cried and tantrumed to get a treat at the grocery store. In this example, the child wasn't born engaging in this behavior, nor did they start with this challenging behavior the first time that they were at the grocery store. Therefore, most behaviors are learned. And this is the case for both adaptive and maladaptive behavior, same processes. So there are four main functions of behavior, and they are social positive reinforcement in the form of access to attention or tangible, social negative reinforcement in the form of escape or avoidance from an aversive event, and automatic reinforcement in the form of positive or sensory stimulation and negative or alleviation of unpleasant stimulation. And we call it automatic because the behavior itself produces the reinforcing consequence. So when trying to identify the function of behavior, it's often helpful to think, what purpose is this behavior serving the individual? And our process for identifying what the purpose or function of behavior is called the functional behavioral assessment, or FBA as it's commonly known. Specifically, this process is designed to identify what about the environment influences behavior. That is, in what situations does the behavior occur and not occur? with the ultimate purpose of discovering a cause-effect relation between the environment and the target behavior. Therefore, the goals of FBA are to understand the conditions under which behavior occurs, determine treatments that are likely to be effective as a result, and then to use this information to prevent the future occurrences of challenging behavior. The primary methods of FBA are made up of three primary approaches: indirect or anecdotal methods, descriptive or naturalistic observation, and functional or experimental analysis. Although the FA is the most precise, it is the least simple of the three assessment methods. Conversely, the indirect methods are the most simple to implement. However, they are the least precise of the assessment methods. So we will discuss characteristics of each of these methods and review their strengths, weaknesses, and suggestions for incorporating them into your practice. So in general, indirect assessment methods use verbal report to gather information about the target behavior. This approach is oftentimes preferred because it's easy, it doesn't present a risk to the client, and it gathers a lot of information in a relatively small amount of time. However, given this information comes from verbal report, it's highly subjective. It has poor reliability and is really insufficient for the treatment development. Therefore, I suggest using the results of an indirect assessment as a preliminary guide and to conduct this across multiple informants and to follow with additional assessments to identify behavioral function. Descriptive assessment methods involve the direct observation of the circumstances surrounding behavior. Data collection typically involves narrative recording that captures the antecedents and consequences associated with the occurrence of the target behavior. This method is more reliable than indirect assessment, given that the measures are objective and quantifiable, and you're basing your hypotheses on direct observation of the behavior in that environment. Although these results may be sufficient for treatment development, there are several important weaknesses that need to be considered. First, the nature of descriptive assessment methods is that it is observation without manipulation. Thus, it identifies only correlational relations. Second, irrelevant variables like teacher attention might mask other relevant ones like escape from classroom instructions, given attention typically follows the occurrence of many behaviors, especially if they're of the disruptive sort. So given this, I suggest using descriptive assessment methods to determine objective definitions of behavior, to determine relevant contextual variables, and then to conduct numerous observations over time and in various contexts to gather all this information, to then inform the conditions and of what your functional analysis will look like. So last but not least, FA methodology is the superior approach because it involves the direct and quantifiable observation of behavior under controlled conditions, and levels of target behavior are compared across the test and control condition, typically using measures of frequency, latency, or sometimes percentage of intervals or trials. As mentioned, this approach is the gold standard because it's the most precise and demonstrates that cause-effect relation. Potential limitations are that it requires an initial investment of time, resources, and expertise to conduct. So I suggest conducting an FA when the function behavior is unknown, and that procedural safeguards are considered to minimize the level of risk throughout the assessment. So next, we will discuss the common elements one considers when designing an FA. Specifically, we're going to review how one selects a target behavior, how one identifies the appropriate setting, therapist, and materials to conduct the assessment, how one decides on the modality of the FA, and what procedural safeguards one should arrange. So a behavior analyst should always use the results of the indirect and descriptive assessments to identify the target behaviors and to help develop operational definitions of those target behaviors. During this time, the behavior analyst can also consider variables like caregiver input and reported severity of the behaviors when determining the priority with which the challenging behaviors should be addressed. Next, the behavior analyst will decide whether or not to assess the target behavior concern in isolation or in aggregate with other potentially related topographies of behavior. The clear advantage of this approach is that it may be easier to lump all these topographies together and deliver program consequences for any instances of these behaviors that occur. Unfortunately, there are important limitations to this approach that behavior analysts need to consider. That is, when making an assumption that all topographies of behavior are related, you're increasing the likelihood of identifying false positive functions for certain topographies, or results that indicate that challenging behavior is multiply maintained when in reality it's not. Therefore, it's recommended to assess topographies in isolation, or if you highly suspect that topographies are functionally related, only aggregate 2 to 3 at most, and be sure to collect data and analyze each. If you suspect that topographies are functionally related, though, it may be beneficial to identify whether relatively minor topographies of the behavior occur prior to the more severe target behavior in a reliable manner. If this is the case, FA test contingencies may be placed on these less severe forms of challenging behavior known as precursors, which may result in an overall safer FA process. We will discuss procedures for conducting precursor FAs later in this presentation. So after you've identified and operationally defined the target behavior, you'll need to consider where the FA will take place, who's going to conduct it, and what materials you will use across each of the test and control conditions. Although many studies have been conducted in inpatient clinics, research has continued to demonstrate that functional analyses can be implemented across a variety of settings. It is on the behavior analyst, though, to decide what setting will be most appropriate given the severity of the challenging behavior and the available setting options. For instance, if the topography is so severe that it may harm the individual, therapist, or environment, perhaps a highly controlled, padded setting is most ideal. However, if the challenging behavior can be tolerated reasonably well within the current environment, perhaps the benefits associated with conducting the functional analysis in the natural classroom environment is the preferred option. So in general, when deciding upon the most appropriate setting, the behavior analyst should be considering variables associated with conducting this assessment in the safest yet most practical setting. So we will discuss strategies for addressing setting constraints later on in this presentation, though. So next, it's critical that therapists are thoughtfully and appropriately selected for implementing the functional analysis. Typically, this requires the involvement of experienced and well-trained behavior analysts and/or researchers. That said, recent research has demonstrated that teachers, staff, parents, all can be effectively trained to serve as within-session therapists of a functional analysis. However, it's important to note that the implementation of the FA was still managed by experienced and well-trained behavior analysts and researchers. Further, this line of research demonstrates that including caregivers as therapists may represent the conditions under which challenging behavior typically occurs, resulting in efficient responding and leading to clear FA outcomes. Therefore, it's recommended to include relevant caregivers into the FA so long as it's safe and practical to do so. The results of the indirect and descriptive assessments should inform the materials you choose to include across all the FA conditions. This information can be supplemented by the results of the assessments used to identify high, moderate, and non-preferred stimuli to include in the relevant test and control conditions. Further, it's recommended to include condition signaling stimuli and appropriate forms of protective equipment for the patient and therapist, depending on the nature and severity of the target behavior. Until recently, we were primarily conducting FAs in person and within well-controlled settings. However, with the need to reach more families, coupled with the advances in technology, conducting FAs via telehealth has become a reality. So although conducting FAs in person is still considered best practice because it's relatively easier to manage procedures and the associated risks, telehealth is a viable solution for delivering assessment services and behavioral consultation to underserved areas. That is, research has demonstrated the efficacy of remote coaching for teachers, parents, and other staff to implement FA procedures across various locations, and it represents a cost-effective and efficient service delivery model. But prior to adopting this model, organizations should consider the startup costs required to set up an effective telehealth delivery model. In addition, it's recommended that behavior analysts are trained on how to effectively utilize this modality and technology to ensure competence before delivering services. Further, behavior analysts must consider the severity of the patient's challenging behavior and the resources available in that individual's environment when determining if telehealth is appropriate. Because FAs are designed to evoke and reinforce the occurrence of challenging behavior, the patient and therapist may be at risk for injury or harm. Thus, once the target behavior has been identified and objectively defined, it's important for behavior analysts to conduct a risk assessment to determine whether the benefits associated with conducting an FA outweigh the risks. In particular, Roscoe and colleagues proposed a risk assessment as a formal clinical decision-making model and recommended assessing and managing risk across 4 primary domains. First, clinical experience of those conducting the FA should be considered, followed by intensity of the target behavior, the suitability of the physical environment in which the FA will be conducted, and the number and composition of support staff available to assist in the FA. So specifically, behavior analysts should ensure medical evaluations are conducted prior to the FA to rule out potential intervening variables and to ensure that adequate professional oversight is present throughout the FA. Next, behavior analysts should ask themselves a series of questions to determine the intensity of the target behavior, including whether the occurrence of behavior will result in bodily harm or injury to the patient or others, whether the behavior is more or less intense in or out of session, and whether or not alternative assessment procedures should be considered in lieu of an FA. In addition, the behavior analyst should determine whether the physical environment in which the FA will be conducted is safe, and if additional safety procedures should be programmed. For instance, if the environment is not well padded, then additional procedures such as response blocking or the use of protective equipment should be considered to mitigate risks associated with the behavior occurring in that environment. Last but not least, the number of support staff available should be responsible for monitoring injuries and preventing escalation, and also capable of administering first aid in the event that minor injuries do occur. So in summary, after a risk assessment indicates the need for safety procedures, behavior analysts should incorporate procedural safeguards when developing and conducting an FA. Furthermore, researchers have developed and evaluated methodological modifications which involve decreasing the occurrence of severe challenging behavior in FAs to address these safety concerns. Next, I will review the process and procedures for conducting an FA. Specifically, I'll start by presenting the current best practice methods for conducting an FA. Then I'll discuss common data collection strategies and graphing conventions. Current best practice recommendations for conducting an FA are based on nearly 40 years of research. In general, standard best practice procedures include incorporating the procedural safeguards based on the results of the risk assessment that we just discussed, conducting an extended alone or no interaction condition prior to the multi-element FA to screen for behavior maintained by automatic reinforcement if that's hypothesized to maintain the behavior. Only including test conditions for those hypothesized to maintain the behavior. Program condition signaling stimuli to enhance the patient's ability to discriminate across different test and control conditions. Limit pre-session access to programmed reinforcers in order to increase the value in those putative reinforcers. Begin by conducting 5-minute sessions. Deliver program contingencies for the occurrence of challenging behavior on a continuous FR1 schedule. Conduct conditions in a fixed sequence to capitalize off the naturally occurring establishing operations. And rapidly alternate conditions using a multi-element design. In order to determine whether each of the test and control conditions you're conducting do in fact set the occasion for instances of challenging behavior, you and your team will need to determine a system of data collection and graphing that will allow for you to measure the behavior in real time and plot it on a graphic display in preparation for visual analysis. Although a skilled therapist may be able to collect data while conducting sessions, this practice is rarely, if ever, used within FA. Thus, a therapist and observer are needed to conduct most sessions so that one can manage the implementation of the session procedures while the other can focus on observing and scoring instances of the patient's challenging behavior. Traditional paper and pencil or data sheets can be used for actual data recording. However, many inexpensive programs and apps are available for recording data on electronic tablets or other handheld devices. Following each session, the behavior analyst converts the data to a measure that is comparable across conditions, such as responses per minute or rate. Then, the behavior analyst plots the data on a line graph and visually inspects the levels of challenging behavior within and across the test and control conditions. Typical graphic conventions for a multi-element functional analysis include scaling the dependent measure, in this case, responses per minute, along the y-axis, and plotting sessions along the x-axis. Given more than one test and control condition are involved within the multi-element FA, it will be important to offer condition labels or a legend to indicate which data path represents each condition. Then these data points are plotted in the order with which sessions are conducted. Then the sequence was repeated again and again and again and again until clear differentiation between a test and the control condition emerges. It's important that a system exists for the behavior analyst to graph the data following each session such that visual analysis can occur in an ongoing manner, and database decisions can be made in the moment to determine if a function is identified and the FA is complete, or if the function is still unclear and more sessions are needed. Now that the FA has been designed and is being conducted and the measures are being graphed, we can discuss how you analyze and interpret the outcomes. Specifically, we'll describe the main variables one considers when engaging in visual inspection. Then, we will discuss some recent research that has evaluated the use of structured visual inspection criteria for interpreting FA outcomes. Finally, we will discuss how to make database decisions with respect to continuing to conduct the FA or the conditions under which you would conclude the assessment. So visual inspection is the mechanism by which we convert data on graphs into decisions. And when applying visual analysis to interpreting FA outcomes, there are some additional rules one must consider when identifying behavioral function. First, interpretation is based on the level, trend, and variability of the data paths in relation to the vertical axis and to that of the control condition for each test condition. Second, when levels of problem behavior are higher in one or more test conditions than in the control condition, the behavior analyst concludes that the FA is differentiated. For instance, here are 3 common response patterns that can occur within an FA. Data presented in the top panel should look familiar because we just looked at them when discussing graphing conventions. So in this panel, the level of responding in the attention condition is differentiated from the control condition, indicating that the behavior is likely maintained by attention. In the middle panel, the demand condition is clearly differentiated from the control condition, suggesting that the behavior is likely maintained by escape from demands. Finally, in the bottom panel, we see an overall higher level of responding in the alone condition, indicating that this behavior is likely maintained by automatic reinforcement. So it's probably clear to you all that each of these graphs display outcomes of a completed functional analysis. However, how do you know for certain? So although visual inspection is a reasonable method of data analysis when FA results are relatively clear, it may not be the most reliable method of interpreting such results. So given the subjectivity of this practice, researchers have developed and evaluated structured criteria to interpret FA data to address this issue. Fisher and colleagues developed and evaluated structured criteria for interpreting FA outcomes. In particular, the authors place upper and lower criterion lines that are 1 standard deviation above and below the mean of the control condition. Then they determine the number of data points below and above the criterion lines to determine if a condition was differentiated. Specifically, a condition is differentiated if 50% or more of the data points from a given test condition fall above the upper criterion line than fall below the lower criterion line. For instance, 100% of sessions in the tangible condition fall above the upper criterion line, suggesting differentiation. Whereas an equal number of data points fall below the lower criterion line than the data points that fall above the upper criterion line, canceling each other out and suggesting that the alone condition here is not differentiated. So not only does this offer a more objective method for conducting visual inspection, but it also produces greater reliability among observers. Additionally, this approach may serve as an important aid when training visual analysis skills to behavior analysts like yourself. This method has been replicated and extended across other FA formats, including trial-based FAs and recently latency-based FAs. Because structured visual inspection criteria provide an objective approach for identifying functions of behavior, it may also result in identifying functions in a much more efficient manner. Unfortunately, this cannot be determined from the studies reviewed previously because the criteria were applied post hoc or after the fact. However, FAs are typically analyzed in an ongoing manner. Therefore, Saney and colleagues extended these procedures by providing rules for ongoing visual inspection, or OVI. That is, the authors applied the criteria while conducting the FA in real time. Results indicated that using OVI to interpret FA outcomes decrease the mean length of the FAs by more than 40%. Thus, using OVI can produce reliable and valid interpretations of FAs in a more efficient manner. These results suggest that using more structured methods for interpreting FA outcomes using OVI may result in identification of the function in a much more timely manner. So now that we've covered all that goes into conducting an FA of challenging behavior, we'll discuss the conditions under which you would need to consider modifying FA procedures to address implementation challenges or clarify inconclusive outcomes. The role of experimental FAs in guiding treatment is well established. However, not all FAs yield conclusive results. Literature reviews of previously published FA studies report inconclusive outcomes in 6% of published FAs. However, given these summaries represent the results of published FA outcomes, it may be that these are subject to publication bias and underrepresented. Hagopian et al. Reviewed FA outcomes from a sample of individuals who all experienced a standard FA within a clinical setting, and results indicated inconclusive outcomes in nearly half the cases. So ultimately, behavior functions were identified across all 93% of cases. However, this percentage was achieved only after making initial and then secondary modifications to FA procedures. So in summary, initial attempts at identifying function in the FA methods typically is anywhere from 6% or 6% to 50% inconclusive. And so maybe about half the time, you're going to need to progress onto more secondary or tertiary FA modifications to identify a clear function of behavior. Therefore, these data suggest that inconclusive outcomes do occur, sometimes fairly regularly, and that strategies for effectively modifying FA procedures are needed. In addition to the antecedent, consequent, and design modifications described by Hagopian et al., Schlickenmeyer et al. Reviewed the FA literature and described idiosyncratic antecedent and consequent variables included in the modified FAs. So taken together, these studies demonstrate that when common and general classes of reinforcers are tested and do not yield clear outcomes, modifications have been made for addressing implementation challenges and for clarifying inconclusive outcomes. These procedural modifications can be applied to address implementation challenges due to the topography of the behavior, time constraints that preclude extended observation and detailed experimental manipulation, setting constraints that preclude a safe environment and appropriately trained staff, and for clarifying undifferentiated outcomes and identifying idiosyncratic functions. So next, I'll present modifications you might consider when faced with each of these scenarios, beginning with how one might address implementation challenges due to the topography of the behavior. The occurrence of certain types of target behaviors can pose several challenges. Specifically, dangerous instances of severe challenging behavior can pose significant risks to the health and well-being of the patient, the therapist, or even the physical environment, and they require the use of alternative methods for conducting a safe FA. In addition, some behavior results in such a significant change to the environment that traditional frequency or rate measures are insufficient for accurately measuring response strength, and alternative methods are needed to effectively identify behavioral function. A potential solution for conducting FAs of severe challenging behavior is to identify precursors to the severe behavior and deliver putative reinforcement contingencies contingent on this milder form of behavior. If no precursor behaviors are identified, then another alternative method is to terminate the session following a single instance of the challenging behavior and measure latencies to the first occurrence of the behavior. Latency-based FAs are also the method you would consider when behavior creates such a significant change to the environment, such that it requires you to stop and reset the session contingency. So next, we'll discuss the methods for conducting precursor and latency-based FAs. So precursor FA involves conducting an FA with relatively less severe challenging behavior, but making sure that it reliably precedes the occurrence of that target challenging behavior. This recommendation is based on research on response class hierarchies, which suggests that potentially less severe or problematic behavior, such as whining and crying and yelling, often precedes the severe challenging behavior and is part of the same functional response class. That is, if I'm not getting my way and I I want to get out of doing my work, I might whine and cry at first. And then if that doesn't work, I might throw my pencil or pen across the room. And then if that doesn't work, I might slam my fists on the table. And if that doesn't work, that still doesn't work for letting me get out of doing my work, I might aggress towards the teacher. And if that doesn't work, then I might aggress towards myself. And then finally, maybe at that most severe form, they might give me a break away. Well, the idea here is that all those responses are all part of the same functional response class, meaning that they all serve the same function. And if we can identify one that's lower in that hierarchy, so instead of waiting for the severe head banging or the aggression towards the teacher to occur, if we can simply reinforce the crying or whining or even throwing the pencil across the room, that's a much less severe, much less lesser magnitude response that we can provide reinforcement for. And in doing so, we're likely to not see the severe escalation of that problem behavior. So it's efficient and safe. So prior to conducting a precursor FA, behavior analysts must first determine which behaviors are precursors. So similar to our FBA methods, some are easier, some assessments or methods for identifying precursors are easier to complete, but they're less precise, whereas others are a little bit more systematic and thorough, but are more complex. Procedurally though, everything is the same as the standard FA. However, instead of waiting for that severe challenging behavior to occur, program contingencies are delivered contingent on that precursor behavior. So to illustrate this, let's review some data. Note that self-injurious behavior is displayed in that top panel, and that precursors are displayed in the bottom panel. In this first phase here, FA test contingencies are only placed on the severe self-injurious behavior. When this is the case, we see high levels of self-injury and high levels of precursors, likely because those precursors, as I mentioned, are happening first, not getting paid, not contacting reinforcement. So then you see escalation of the severe self-injury. Now in this second phase, FA test contingencies are only placed on precursors. When this is the case, you see precursors occurring at relatively similar levels, actually somewhat decreased. And this is likely because in the previous phase, they were having to occur many times, contacting extinction before bursting and resulting in extinction-induced variability, which then is moving up the hierarchy to more severe forms. Now, when precursors are being reinforced, they only have to happen one time to contact reinforcement. So it's a more efficient responding that you're seeing in this phase. Also, when you look at the severe problem behavior, it's not occurring when you're reinforcing precursors. So this is clearly effective at reducing the severe behavior from occurring within the functional analysis. Thus, FAs of the precursor behavior should allow one to infer the function of the severe challenging behavior based on the outcome of the FA of the precursor behavior. So finally, there's two primary limitations associated with precursor FA methodology. First, researchers have yet to determine the most effective strategy for identifying precursors reliably, and doing so in a timely manner. Thus, researchers suggest behavior analysts use precursor FAs only when precursors can be readily identified and easily incorporated into the assessment. Second, there may be individuals who do not present with any identifiable precursor behaviors, making this approach irrelevant for such cases. So another method then for increasing the safety and efficiency is the use of latency-based FA, which involves using a latency measure to the first occurrence of challenging behavior rather than repeated measures within a session. So in this case, shorter latencies to the target behavior within a particular test condition indicates a sensitivity to the programmed antecedents and consequences within that condition as compared to longer latencies or zero instances of the target behavior in the control condition. Further, the therapist delivers the programmed consequence and then terminates the session once that behavior occurs. Thus, conditions in which shorter latencies to the first occurrence of challenging behavior are observed as compared to control conditions suggest variables that maintain challenging behavior. So in addition to potentially increasing the safety and efficiency of FAs for severe challenging behavior, latency-based FAs have several other potential advantages. First, the use of the latency measure may avoid the potential confounds from the use of blocking or wearing of protective equipment. Second, a latency measure may be useful in situations in which the occurrence of the severe behavior, such as elopement, makes it difficult to restore the original environmental condition, such that behavior can recur within session. Third, some challenging behavior may be best assessed using latency measure because the occurrence of the behavior is limited due to the patient's physiology. Despite these strengths, there are some potential limitations with this approach. First, because sessions are terminated contingent upon the first occurrence of the target behavior, this approach limits an individual's exposure to the number of session contingencies, which may interfere with their ability to discriminate across the conditions. However, this concern can be partially mitigated with the use of condition signaling stimuli to help enhance discriminability. Second, because there's no repeated measures within session, this limits our ability for within session analyses, which can be useful for clarifying functions of behavior. So next, I'm going to review methods for addressing challenges due to time constraints. Several factors may critically limit the amount of time available to conduct an FA. For instance, the time that a behavior analyst is able to dedicate to assessment may be limited due to patient availability or the urgent need to move into treatment. When these challenges arise, several solutions exist, depending on whether or not there is a hypothesized function. That is, if the team has a pretty good idea about what the socially maintained behavior might be, then I recommend conducting a pairwise FA. If it's hypothesized that the behavior may be maintained by automatic reinforcement, then I recommend conducting an extended alone or no interaction condition to confirm this. And if it's unclear what the function may be, then I recommend conducting a brief FA. Next, I'll review each of these in a little bit more detail. So if the information gathered during indirect or descriptive assessment strongly suggests there's only one or two hypothesized functions, the behavior analyst may choose to only focus on designing test conditions to assess each of these and need not worry about conducting the other test conditions. This design is similar to that of the multi-element that conditions rapidly alternate. However, only a single test and control condition are conducted at the same time, and these series are then conducted in a sequential manner. For instance, in this initial phase, you see the escape test rapidly alternating with the control condition. Once a function is confirmed, then they move on to the next sequence. In the second phase, you see the attention test rapidly alternating with the control condition. And once this is demonstrated to not be a function, then they moved on to the next phase and so on. So the strength of this approach is that it's a focused analysis that produces results quickly so that treatment can begin. And it's ideal for patients who do have difficulty discriminating across many different conditions. The primary limitation of this approach is that other functions may be missed because they were not originally hypothesized and therefore omitted from the assessment. Second limitation is that if two or more test conditions are included within the analysis, this may actually represent a less efficient approach as compared to the typical multi-element design, given that the number of additional control sessions are being conducted. If it is hypothesized that the challenging behavior may be maintained by automatic reinforcement, then consecutive alone or no interaction test conditions may be conducted to determine whether target behavior persists in the absence of social contingencies. So if target behavior persists across alone or no interaction conditions, then the outcome suggests an automatic reinforcement function, and the behavior analyst can then move into intervention. However, if target behavior decreases across condition, this outcome suggests maintenance by social contingencies, which would then require further assessment, either a pairwise or a brief FA. The strength of this approach is that it serves as a screener for automatic reinforcement so that it can be ruled in or out. It's an efficient approach, and it can allow the team to move into treatment as soon as a function is identified. So even if you do not have a hypothesized function, methods for conducting a brief FA exist. The brief FA conducts one test condition probe for each hypothesized function. During these sessions, data is often collected on whether an appropriate alternative response occurs during the FA, in this case, a manual sign. If a test condition is indicated, then a contingency reversal phase is conducted in which the hypothesized reinforcer is now delivered contingent on that appropriate alternative response to demonstrate the validity of the brief FA and indicate a potential function-based treatment. The strengths of this approach are that it can be completed in less than 90 minutes, which is ideal for brief outpatient visits. Also, given the brevity of the assessment, the patient spends less time in the evocative conditions, which means less challenging behavior, resulting in a potentially safer approach. This approach is associated with some rather significant limitations, though. with two of the most critical being limited demonstration of experimental control within and across conditions, and the fact that sometimes behavior does not occur within the context of a 90-minute session. So next, I'll review methods for addressing challenges due to setting constraints. Challenges related to the setting within which you're planning the FA can arise if there's limited space, staff, or resources available to conduct the assessment. Under these circumstances, a possible solution might be conducting the FA in the client's everyday environment as the naturally occurring antecedents and consequences present themselves using a trial-based FA. That is, therapists conduct brief trials, anywhere from 3 to 5 minutes in duration, that begin in a control segment, transition to a test segment, and then conclude on a control segment to test potential reinforcers for challenging behavior. During the test segment, the therapist implements programmed antecedents and consequences. However, contingent upon the occurrence of the target behavior, the therapist delivers the putative reinforcer and then begins the control segment. The percentage of trials with target behavior in each test condition is compared to the percentage of trials in the relevant control condition. For the escape from demand test, more instances of behavior occur during the control as compared to the test segments, indicating that this is likely not the function. However, many instances or percentage of intervals of aggression occurred during the tangible test trial segments, and no instances occurred during the control. Therefore, it's safe to conclude that Allen's aggression is likely maintained by access to tangible items. Some of the primary advantages of implementing trial-based FAs is that they're easy to implement by caregivers and more applicable to assessment during ongoing activities in the natural environment. Although trial-based FAs provide a simple, convenient, efficient, and relatively effective method for determining the function of challenging behavior, several potential disadvantages of this approach exist. First, the short trial durations of trial-based FAs result in minimized exposure to the putative establishing operation, which may be insufficient for evoking challenging behavior. Second, 40% of trial-based FAs conducted in previous studies did not result in accurate predictions of behavioral function, and extended analyses were required to determine the responsible maintaining variables. Next, I will review methods for clarifying undifferentiated outcomes. Although FAs often result in clear outcomes, inconclusive or undifferentiated outcomes sometimes occur. These outcomes might include low levels of behavior across all conditions, high levels of behavior across all conditions, or variable levels of behavior across conditions. Potential reasons for this could include carryover effects due to difficulty discriminating across multiple test and control conditions, limited exposure to relevant establishing operations. The programmed antecedent consequences do not resemble those that exist in the everyday environment. The program consequences are either irrelevant or just not potent enough. In addition to the best practices and considerations for designing and conducting FAs discussed already, several other strategies for clarifying outcomes should be included to increase the clarity, safety, and efficiency of FAs. These include modifying the experimental design to minimize risk of carryover effects by conducting the FA in a pairwise or reversal design, or making procedural modifications to increase session duration to enhance exposure to potentially relevant establishing operations. Conducting additional assessments to identify information you may have missed the first time around that may be used to inform more specific antecedent or consequent modifications. Then, once some idiosyncratic variables have been identified, conduct these modified FAs or additional test conditions in an attempt to clarify undifferentiated outcomes. Next, I'll review strategies for identifying idiosyncratic functions. FA is a process by which behavioral function is identified. Therefore, when common and general classes of reinforcers are tested and do not yield clear outcomes, modifications have been made to enhance the putative establishing operation or consequence during test conditions in order to successfully capture the relevant antecedent and consequent events responsible for evoking and maintaining the challenging behavior in the natural environment. Next, I will review 3 types of modifications behavior analysts make when attempting to identify idiosyncratic functions. These are antecedent event modifications, consequent event modifications, and some combination of these modifications. Generally, antecedent event modifications involve creating a more salient discriminative stimulus or enhancing the putative establishing operation across the traditional test conditions of escape, attention, and tangible. Examples of modifying the escape condition antecedent to capture the relevant evocative conditions include using common assessment methods to identify potential demands for FA test conditions, or programming longer exposure to task presentation. That is, demands are most often selected arbitrarily or based on caregiver report. Therefore, studies have demonstrated the utility of various assessment methods to identify aversive stimuli to then include in the negative reinforcement test condition. Examples of modifying the attention condition antecedent to capture the relevant evocative conditions include the delivery of attention to another person rather than engaging in just a solitary activity, or the therapist leaving the room entirely, as potential strategies to create a more salient discriminative stimulus or to enhance the establishing operation for attention. Examples of modifying the tangible condition antecedent to capture the relevant evocative conditions include the therapist enticing the patient by playing with or consuming the removed leisure item. And sometimes you can be playing with it correctly and making it look fun and amazing, or you can play with it incorrectly. And each way may be approaches to enhance the establishing operation for that individual accessing the item. Next, consequent event modifications generally involve improving the quality and magnitude of the program consequences across the traditional test conditions of escape, attention, and tangible. Across all types of conditions, modifying the magnitude of the consequent event is accomplished by increasing the duration of access to this putative reinforcer. An example of modifying the quality of the consequent event in the escape condition is by somehow improving the conditions of the escape period. For instance, perhaps removing a response blocking component if this resulted in a lower quality period of escape. An example of modifying the quality of the consequent event in the attention condition is by identifying preferred conversation topics and delivering them this form of attention contingent on the target behavior. An example of modifying the quality of the consequent event in the tangible condition is by either identifying preferred leisure or edible items and providing access to multiple putative reinforcers at once, contingent on the target behavior. It may also be advantageous to consider providing these antecedent and consequent event modifications in combination with each other. That is, although 90% of published FAs reported using an isolated test contingency to effectively identify behavioral function, sometimes there is a need to identify multiple or to modify multiple events within a test condition in order to identify less common idiosyncratic functions. Slayton and Hanley conceptualized the nature and scope of synthesis in FA literature along the continuum presented here that spans from isolated to synthesized. You'll notice that there are multiple variables that can be synthesized and that these can occur in various combinations across this continuum. I will focus on reviewing examples of synthesizing establishing operations and reinforcers next. Examples of synthesizing establishing operations include presenting demands when the patient is either also dealing with allergies or sleep deprivation, withholding preferred leisure items while the patient is sleep deprived, withholding a preferred leisure item while also presenting demands on the patient, or withholding both attention and access to preferred leisure items as a method of synthesizing antecedent events to create the evocative conditions in an idiosyncratic FA test condition. Examples of synthesizing reinforcers include escaping caregiver-led activities to access patient-directed activities, escaping response blocking procedures to access automatically maintained ritualistic or stereotypic behavior, accessing therapist interaction while engaging in preferred leisure items, escaping work to access therapist attention and preferred leisure activities, or escaping caregiver-directed instructional activities to access therapist attention, preferred leisure activities, and patient-directed activities. So just like anything, there are clear advantages and limitations to this approach. The advantage of synthesizing antecedent or consequent events in order to create the environmental conditions that allow for capturing idiosyncratic functions is that it may better reflect co-occurring stimulus changes in the individual's environment, thus increasing the likelihood of identifying a condition that evokes and maintains target behavior. However, the limitations of this approach are that you critically decrease experimental precision. That is, once you start combining and synthesizing antecedent and consequent events, it becomes unclear what about your test condition is responsible for evoking and maintaining the behavior. And this is problematic because the entire point of conducting an FA is to determine the precise conditions responsible for maintaining behavior in order to design an effective function-based intervention. Therefore, given the well-documented rarity of idiosyncratic functions and multi-maintained behavior, coupled with research recently suggesting that synthesized conditions did not appear necessary for any participants for which it was conducted, I recommend that you only synthesize antecedent and consequent event conditions to identify idiosyncratic functions after tests for isolated functions are inconclusive, or hypotheses following indirect and descriptive assessments strongly suggest an idiosyncratic function. At which point, you should also conduct an isolated contingency analysis in addition to the synthesized contingency to rule this hypothesis in or out. Next, I will review some general recommendations when it comes to conducting FAs in practice. Specifically, I will cover suggested FA progression and decision-making models and review what emergency procedures you might look like in the event that behavioral episodes are occurring at such a high rate, magnitude, or severity outside of the FA, such that a more immediate short-term solution is needed. So first, we're going to review the research and recommendations for adopting FA progression models. So researchers have proposed a method of progressing from relatively brief to more extended analyses as needed when behavioral function is not identified in an attempt to efficiently conduct FAs. Specifically, a given assessment phase is conducted until differentiated response patterns are produced or undifferentiated patterns stabilize, indicating inconclusive outcomes. When differentiated patterns emerge, indicating a function, the assessment concludes and you move into treatment. However, if outcomes are inconclusive, then assessment progresses to the next, more involved phase. In the model originally proposed by Vollmer and colleagues, phase 1 began with conditions very similar to a brief FA. Now, if the results were differentiated here, then these individuals moved on to treatment. However, if results were inconclusive, then they moved on to a full multi-element FA. In the multi-element FA, if the multi-element FA produced differentiated results, then they moved into treatment. However, if results were inconclusive, then they moved on to the extended no interaction condition. If responding persisted during the no interaction condition, then they moved into treatment. But if responding extinguished, then they moved on to implementing an FA in a reversal design. Results demonstrated that function was identified for 6 of 20 patients within that first phase. For 4 of the remaining participants within the second phase, for 5 of the remaining participants in the third phase, and for 2 of the remaining participants, for a total of 17 of 20 participants, or 85% total, for whom this model effectively identified function. The results of using an FA progression model suggest that decisions about assessment length can be data-based and does not always require a large number of sessions or complex procedures to identify functions of behavior. In fact, several of the assessments were completed in less than 2 hours. Recently, Henry and colleagues replicated and extended this study by updating the model for progressing from brief to extended experimental analyses. In particular, the model incorporates several procedural refinements and additional conditions developed over the past 20 years to confirm or annul findings. This included beginning with a screener for automatic reinforcement, programming fixed reinforcement times across conditions, programming session correlated stimuli across conditions, and conducting the conditions in a fixed sequence. Overall, the results suggested that the updated model produced the clinical information necessary for treatment selection and implementation for all 20 participants, suggesting that this updated model is as effective, if not more so, at identifying functions and moving to treatment in a relatively efficient manner. Therefore, the researchers recommended adopting this clinical model when there is a need for brief assessment, given practical and time constraints, and should only conclude when the assessment conclude the assessment when differentiated results are obtained and time and resources are especially limited. When possible, behavior analysts should conduct extended multi-element FAs, and if undifferentiated at this point, behavior analysts should then progress to the use of alternative designs. Next, we will discuss the utility of a more comprehensive decision-making model. So this decision-making model closely aligns with the considerations and recommendations provided throughout this presentation. Therefore, this visual may serve as a useful tool for behavior analysts who are deciding on what FA format to choose when considering potential implementation barriers. So next, I'm going to briefly walk through each of the decision points on this decision-making model. So first, once it has been decided that an FA will be conducted, the first question you might ask yourself is the topography of the challenging behavior high risk or dangerous? If yes, you'll ask whether there are identifiable precursor behaviors in the patient's repertoire. If yes, you might consider conducting a precursor FA. If no, you might consider conducting a latency-based FA. If the behavior is not high risk or dangerous, you'll ask yourself if the behavior requires that the session be reset each time it occurs. If it does, you might consider conducting a latency-based FA. If it doesn't, you'll then ask yourself whether there are any time constraints that need to be considered. If yes, and you hypothesize that there's a social function, you might consider conducting a pairwise FA. If yes, and you hypothesize that there's an automatic function, you might consider conducting an FA screener. If yes, but you do not have a clear hypothesis for behavioral function, you might consider conducting a brief FA. If there's no time constraints, then you'll ask yourself, are there any setting constraints? If yes, you might consider conducting a trial-based FA. If not, then you might consider conducting a standard FA that incorporates all the best practice procedures described earlier in this presentation. Finally, in the event that you refer to a case that is already engaging in behavior at such a high rate and magnitude that you must first create a safe and stable environment prior to even thinking about conducting an FA, I will next review some emergency procedures you might consider. First, the priority will be to create a safe space for the patient. That is, remove all sharp, breakable items from the environment, protect windows, light fixtures, and other breakable surfaces, secure exits and block off parts of the environment that should not be accessed or is harmful if accessed, such as the kitchen or bathroom. Consider the use of protective equipment for the patient, therapist, and environment. Ensure caregivers are trained in de-escalation and therapeutic restraint procedures. So consider all these things, and there's likely more, but thinking along these lines will really help to create a safe space in the event that, to prevent problem behavior, the high magnitude problem behavior, and in the event that it does occur, to help respond to it in a safe manner. In addition, you're going to want to try to eliminate all potential evocative stimuli and events in the environment that you can. Again, that you can, because some of these are a little bit challenging to always deliver or consistently remove, but just need to be considered. So this can be accomplished by removing all instructions or other aversive stimuli in the environment, so not placing any demands if possible. By delivering preferred forms of attention on a relatively dense schedule, so making sure that you're available, you're checking in, you're basically providing non-contingent attention, and making sure that the caregivers know how to deliver this and know what those preferred forms are. Or it could be that the client doesn't want attention, and so you'll have to be mindful of that. Because if you do provide attention, that could be attention in your interactions aversive, that could be an evocative event that produces problem behavior. So want to be careful and know the individual. Also, what you're probably going to want to try to do is make all highly preferred leisure and edible items freely available within reason. I know that there's recommendations out there for screen time, and obviously we don't want them, plowing through a whole bag of M&Ms or multiple bags of M&Ms a day. But these are all things that we'll just need to consider because if this is truly an emergency situation, you're going to be wanting to consider anything to get the severe problem behavior from occurring. If the behavior is that severe that we don't want them to engage in it, I'd much rather have them eat a bag of M&Ms in the moment as a short-term solution to prevent or mitigate severe instances of problem behavior from occurring. So not ideal, not a long-term solution, but in an emergency situation might be worth considering. Now don't go out there and say, well, Briggs told me to give him M&Ms. It's not what I'm advocating for, but just simply saying we need to maybe be a little flexible, especially during these emergent situations, and consider what are the things that they are motivated to access, and allowing them to access those. So if it does prevent the escalation until we can get behavior stabilized and get them in for more thorough functional analysis. And also, if the individual can request and can indicate their wants and needs, responding to all appropriate requests for any of the above reinforcers, obviously within reason. If they ask to go to Disney World, can't get up and go do that right now. But for the most part, there's a lot of things that we can and are able to provide, especially if it is forms of attention or removing certain task demands. If behavior can be safely managed with these procedures to the point that it becomes stabilized, then you may proceed to conducting a functional analysis. However, if behavior still cannot be safely managed with these procedures, then you might consider admitting the patient to an emergency room of a local hospital. Again, this is worst case scenario, but it's the best and safest choice in the moment. Usually this is when parents, caregivers cannot safely respond anymore. They're getting harmed, the individuals engaging in self-harm, maybe they're targeting siblings in the home, and it's at the point where it cannot be safely managed anymore. It's a tough decision, but it's a decision that sometimes has to be made. Just a short-term solution. It's not going to cure the behavior, but it's a short-term solution that may need to be considered. At this point, you might also consider looking for intensive inpatient or outpatient behavioral service settings, or even considering options for long-term residential care. At this point, to get the ball rolling, looking at all the options, because the likelihood is if it's already at a point where you cannot manage it in the home, resulting in you having to go to ER, it's likely that might happen again. If you don't get the behavioral services that you do need. And so thinking long-term about where are we going to go in a year from now, and 5 years from now, and 10 years from now. And so potentially considering all these options as a reality. So obviously this is not ideal, and it constitutes a major decision in an emergency situation. However, it may be the best available option given the history, the severity, and the availability of therapeutic options for keeping the patient safe. So, as is the case with most things, our methods for conducting safe and efficient functional assessment procedures in a practical manner are ever improving in an attempt to become safer, more efficient, and even more practical. Therefore, I will briefly cover some general future directions researchers are currently exploring. So in general, we need studies that continue to ask questions related to conducting FAs in a safe and efficient manner. This may include progressing from brief to extended analyses, or using a decision-making flowchart in order to identify the most safe and efficient approach given the presenting behavioral concern. Another way to accomplish safe and efficient FA outcomes is by determining structured methods for conducting visual inspection in an objective manner, which might result in identification of function in a more efficient manner and thus decrease time spent in the overall assessment process. From the moment FA methodology was introduced, there has been a steady effort to address practical concerns and barriers one may face when conducting FAs in a clinical environment. These barriers may be related to effort and complexity of conducting the assessment, or the time and resources it requires to complete. Given that recent research reports that a significant proportion of behavior analysts still do not conduct FAs in practice, this indicates we as a field still need to understand these concerns and address these barriers. Now that we have close to 4 decades of FA research, it's safe to say that we've a pretty good understanding of the conditions under which challenging behavior is evoked, when it emerges, and how it's maintained. Therefore, we can use this information to offer guidelines for proactively arranging environments and establish prevention programs in schools and early intervention clinical settings with populations who are at risk of developing challenging behavior. Finally, FA methodology is only as good as the intervention it informs. Therefore, continued efforts to improve upon current functional communication training research and practice, and methods for programming durable treatment effects that prevent or mitigate relapse are needed. Thank you for your interest and engagement. If you have any questions or would like to request slides, please email me at the address seen here. Further, if you are interested in this topic and are curious to learn what sort of research we're up to in the Behavior Analysis Research Lab, please visit our newly launched website or follow our activity on social media. Thank you.